Next, next on the agenda are two bills concerning health entity ownership. Vice Chair Ryer, I understand that you have testifiers who will be presenting on both bills before we take them up. Is that correct?
That's correct, Mr. Chair.
So I believe we will start with Dr. Singh from Brown University. Is he on video? Dr. Singh, if you can hear us, please introduce yourself to the committee and proceed with your presentation, please.
Good afternoon. My name is Yashaswini Singh. Thank you, co-chairs Becker and Bierman and members of the House Health, Finance, and Policy Committee. I appreciate the opportunity to testify before you today to provide an overview of private equity investments in healthcare. I am an economist by training and a professor at Brown. I also serve on the advisory council of the Private Equity Stakeholder Project, a consumer watchdog and advocacy organization interested in private equity investments in all sectors of the American economy. I wanted to start by providing an overview of PE investments in healthcare. Private equity firms have invested over $1 trillion in the American healthcare system over the last 2 or 2.5 decades. This has really accelerated starting in the period, as you can see on the chart, around 2015 onwards. I also wanted to spend a brief moment describing to you how private equity in particular might differ from other types of private or for-profit ownership in healthcare.
Excuse me, Dr. Singh? Could you speak up just a little louder? I think we are maxed out on audio here, and if you could speak a little louder, that would be helpful, please. Thank you.
Absolutely. I hope this is better. I thought I would provide an overview of how private equity in particular differs from other types of private or for-profit ownership and investments in healthcare. Generally, private equity firms rely on large amounts of debt to acquire majority or controlling stakes in the targets that they invest in. Investors typically have a short time horizon, generally investing for a period of 3 to 7 years, and they often seek returns that far exceed market averages, often upwards of 20%. And so the emphasis really is on rapid value creation and exit rather than long-term investments. Of note, PE firms have very few systematic disclosure or transparency or reporting requirements. There are very limited requirements on ownership structures, financing, or performance. This makes it incredibly difficult for researchers, policymakers, patients, and healthcare workers to understand which entity is operated or controlled by PE investors, and most importantly, what the effects of these trends are on healthcare prices, access, quality, as well as workforce considerations. I also wanted to highlight that there is no such thing as a common PE strategy. PE firms operate in distinct ways in distinct healthcare settings. For example, it is common for investors to follow a platform and add-on consolidation strategy when investing in outpatient practices, such as physician offices. But on the other hand, it is also common for investors to rely on sale-leaseback agreements that separate the property company from the operating company, which is commonly seen in investments in hospitals and nursing homes. A little bit more detail on that point. I already highlighted PE firms' extensive use of debt to finance the transaction. Combined with capital that is raised from limited partners, PE firms can use large amounts of debt to make a majority stake investment. In this illustrative example, in a platform practice of three physicians in one practice. Depending on the state corporate of practice medicine doctrine, this can be accomplished via the use of a management services organization, an independent entity that often provides administrative support for back-end functions. The platform and add-on consolidation takes this form. What starts as an initial acquisition of three physicians in one practice is followed by an add-on acquisition of a practice with 2 physicians, add-on acquisition of practice B of a solo practitioner, and add-on acquisition of practice C with 4 physicians. Together, this platform and add-on model gives the same firm control over 10 physicians, even though each individual acquisition was too small to trigger any sort of reporting or disclosure requirement. Importantly, this type of roll-up consolidation offers the PE investor market share, the ability to benefit from economies of scale, and then exit the investment for a higher valuation. Theoretically, PE firms can exit their investments via taking the investment public, listing it on a public stock exchange via an IPO, selling to another private equity firm via a secondary buyout, or selling to a corporate entity that might be a health insurer or a hospital system. Now, theoretically, while each of these is equally plausible, my research has shown that to date, physician practice exits take the form of secondary buyouts, where PE firms sell their investment targets to other PE firms. The reason I lay this out in this flowchart is to highlight to you that no part of what I illustrate here is formally reported or disclosed in any capacity, making it virtually impossible to track which firms invest in which entities, which communities are exposed to the benefits or the harms of these investments, and also when and what form PE exits take. Now, I have spent the last 5 years studying the effects of these trends, compiling data from hand-collected sources and very expensive proprietary private databases. I wanted to highlight for you what some of this research has found. While there are theoretical benefits of private investment, in general, these have not been supported by empirical research studies. The evidence to date shows that PE investments in outpatient practices increase the cost of care by 10 to 26%, depending on the specific service being examined. PE investors also increase the use of ancillary services such as lab tests and imaging services. There are also some workforce changes that materialize following acquisitions, such as a heavy reliance on advanced practice providers and a greater turnover among physician staff employed by these practices, perhaps signaling an overall dissatisfaction with the performance-oriented nature of work under financial investors. There is also research that PE investors harm patient care, specifically in the hospital setting and the nursing home setting. We see a higher incidence of adverse events as well as patient mortality. The effects of PE on quality of care in the physician setting is more mixed, finding marginal, if any, changes. I also wanted to highlight for you some specific data on Minnesota. Nationally, PE firms currently own and operate over 1/3 of methadone clinics or opioid treatment programs. This is an area of bipartisan policy concern, given that opioid treatment programs are the only licensed setting where methadone can be dispensed. In Minnesota, we have compiled data that shows PE firms currently operate about 20% of the state's opioid treatment programs, and national data show that these investments have not led to an expansion of methadone access or any change in patient mortality. I finally wanted to highlight for you a resource that is compiled by the Private Equity Stakeholder Project. This is a resource that compiles what is referred to as a private equity's risk index, an approximation of PE involvement in each state across the U.S. The Private Equity Risk Index gives Minnesota a risk score of 46 on 100. I wanted to highlight for you that while this resource exists, it is most certainly an underestimate and undercount of PE involvement in healthcare, notably because of the restrictions on transparency and reporting that we discussed earlier. Finally, to conclude, I wanted to highlight for you PE in healthcare across the country has manifested in investments across hospitals, physician practices, nursing homes, as well as opioid treatment programs. Most of the evidence to date is national in scope. We are very limited by state-specific data, and as a result, we have really no grasp on how many hospitals or what share of providers across physician practices or nursing homes are currently affiliated by PE investors. And so in sum, I wanted to highlight that PE's growth in healthcare reflects a broader trend towards healthcare corporatization. The evidence to date supports some of the undesirable impacts of these investments, although theoretical benefits might exist in certain cases. Specifically, we are concerned about higher prices across specialties of care, changes to service provision based on profitability, and some workforce disruptions that have implications for patient care and care continuity. I also highlighted for us how PE strategy is sector-specific, which means that there is likely to be heterogeneity in impact across payers, patients, and workers, but state-specific evidence is limited by the fact that there are no transparency or disclosure requirements to date. And so in sum, I want to close by acknowledging the key regulatory challenge, which is to balance the need for capital investment in healthcare, particularly among smaller independent practices, with protections for patients and healthcare workers. Thank you very much, and I appreciate the opportunity to testify.
Thank you, Dr. Singh. Thank you very much. Next up would be Mr. Sam Brooks.
He was the Hi, thank you very much, Chair and members of the committee. My name is Sam Brooks. I'm really grateful for the opportunity.
You could, Mr. Brooks, speak up a little bit louder, please?
Sorry. I'm grateful for my name is Sam Brooks. I'm grateful for the opportunity to address the critical problem of private equity investment in nursing homes. I'm a national expert on nursing home policy. I direct the public policy program for the National Consumer Voice for Quality Long-Term Care. We are a resident and family advocacy organization and been doing this for 50 years. We see daily the negative and deleterious impact private equity investment has on nursing home residents, their families, and nursing home workers. I strongly support the legislature's efforts to protect its most vulnerable citizens through legislation to prevent the ownership of nursing homes by unscrupulous investors who are only concerned with maximizing profits at the expense of care and communities. Over the past decade, as Dr. Singh indicated, private equity firms have rapidly expanded their presence across the nation's long-term care sector. Estimates show that private equity now own between 5 to 13% of U.S. nursing homes, although I suspect that number is larger, but as Dr. Singh indicated, it's very hard to tell who owns a nursing home. This rise has occurred despite mounting evidence that private equity's profit-driven acquisition strategies conflict sharply with the needs of vulnerable nursing home residents who rely on stable staffing, transparency, and continuity of care. Private equity investors seek high returns and look to industries with guaranteed cash flows, such as Medicare and Medicaid dollars, and to insufficient oversight and regulation on how that taxpayer dollars are spent. Multiple national studies show that private equity ownership is associated with worse nursing home resident outcomes, including increased mortality, higher rates of pain and pressure ulcers, more hospitalizations, and more serious deficiencies. The most comprehensive systematic reviews covering studies from 2000 to 2024 conclude that private equity ownership and involvement in nursing home care results in declines in quality and increased risk for residents. These negative outcomes are not isolated. They reflect structural financial practices. When facilities are purchased using leveraged buyouts, the nursing home is immediately saddled with debt, diverting funds from staffing and care into interest payments, management fees, and leaseback arrangements with private equity affiliated real estate entities. Studies document increases in management fees, lease costs, and interest expenses after acquisition, with corresponding decreases in quality and long-term financial sustainability. Private equity and other unscrupulous owners use nursing homes as collateral to fund exorbitant mortgages, which are in turn paid directly by the nursing home. These exorbitant capital costs draw money away from residents and workers and result in poor care. Nursing home staffing, especially among certified nursing assistants and licensed practical nurses, declines consistently under private equity ownership. National analyses show reductions in total staffing hours with only minor or inconsistent increases in RN time. Workforce reductions contribute to higher deficiency rates and lower CMS star quality ratings, consistent with findings that private equity-owned facilities rely more heavily on lower-skilled staff and experience significantly high staff turnover. This impacts staff and the communities they live in. Perennially low wages result in workers living at or near their poverty line and relying on public benefits such as food stamps or Medicaid. The dollars diverted away by private equity that were intended to support high-quality, long-term health care workforce go to the profits of private equity. Recent years have seen several high-profile bankruptcies among private equity-owned nursing home chains, including LaVie, Consulate Healthcare, Goldner Capital, and Gulf Coast Healthcare. These cases illustrate how debt-heavy, extraction-focused financial models destabilize nursing home operations. These bankruptcies are often structured to allow owners to offload debt while retaining the properties. As a result, the practice repeats itself over and over again. This was evident in the 2000 2025 analysis of the Genesis Healthcare's collapse. It showed how leveraged buyouts burdened facilities with massive debt. Genesis owed $700 million to secured creditors, mostly mortgages, when it filed for bankruptcy, leaving residents and workers vulnerable when the financial model inevitably buckles. The private equity investors sought to offload mortgages, which are in turn paid directly by, offload unsecured debt, mostly civil judgments against them for providing such poor care and retain the facility. Minnesota lawmakers are beginning to recognize the risk. Bill 2771 and 2972 propose requiring transparency, attorney general approval of acquisitions, and assurances that private equity ownership will not undermine the quality of care or infrastructure. These bills mandate that at least 75% of public program funds be spent on direct resident care, an essential guardrail preventing harmful extraction. This money are sucked out of Minnesota and into the pockets of people living in New York and other places. Older and disabled Minnesotans deserve stability, dignity, and high-quality care, not exposure to the volatility inherent in private equity's short-term, extraction-driven business model. Nursing home residents and workers are not financial investments. The evidence is overwhelming. Private equity ownership too often leads to cost-cutting, workforce reductions, operational instability, and even facility collapse. Minnesota has a unique opportunity to lead the nation by adopting strong, evidence-based safeguards that place residents, not investors, at the center of long-term care policy. Thank you for your time. I'm grateful for the opportunity to testify, and I welcome any questions. Thank you.
Thank you very much for your presentation, Mr. Brooks.